So good afternoon, everybody, and welcome to our next Pentax medical webinar for COVID-19 to support you and your markets.
My name's Monique Dalton, and I'm the Product Marketing Segment Leader for ERCP and Hygiene Solutions at Pentax EMEA. Today, I'll be your moderator for the webinar.
As you've already seen from our flyer, today we're really focusing on the transition from the COVID-19 emergency into the next phase and how the departments are managed from a people, process and product perspective. And today I'd really like to welcome two key experts. Our first expert is from France, Professor Didier Lepelletier. He is the Professor and Head of Hygiene at the University of Nantes in France, so very much welcome. And our next key expert is Professor Paolo Arcidiacono, Associate Professor of Gastroenterology and Head of the Pancreatic, Biliary, Endoscopy and Endosonography Division at the Vita-Salute San Raffaele University in Milan in Italy. So a very warm welcome to you both. And just to give you an overview of the program for today, our key experts will give you an overview, as I mentioned, of the management of the departments. Professor Lepelletier from the hygiene perspective, explaining what's new with the viruses, talking about guidelines and also about PPE. And Professor Arcidiacono will bring this theory really into practice and explain the management of his department in Milan in Italy. So just some logistical topics. So first of all, just to ensure the webinar runs as smoothly as possible, it would be really great if everybody could put their microphones on mute, if not already done so. And in addition, of course, at the end of the key experts' presentations, we will have a question and answer session. And during this question and answer session, we will answer all of your questions that's possible time-wise. And if you can see on the right side of your screen, you should see a question box. You can write your questions in this area during the webinar, and I will collect all of the questions and then ask the key experts the questions. Of course, if we run out of time, which from our last webinar, we were inundated with questions from the market. And what we will do, if we don't have time to answer them, we will collect those all and we will supply the questions and answers through our LinkedIn channel. So we've got a great topics and great presentations ahead of us. So I would like to hand over to our first key expert, Professor Lepelletier. Thank you.
Thank you. Good afternoon, everyone. And I would like to thank all the Pentax medical team to organize this webinar. This second webinar after the first one that been held last April. So I guess I have to chair and to take. Oh, it's okay. Okay. Effectively, I'm an hospital doctor. I'm an infection control practitioner. I have also a national activity in France, as I'm the co-president of the national working group on COVID-19, and I'm also the president of the scientific committee of the French Society of Hospital Hygiene. So through several slides, I would like to first of all present you my retroprocessing center here in the Nantes University Hospital. The Nantes University Hospital, it's a large hospital with 3,000 beds and around 1 million patients a day every year. So you can see in this slide some pictures of our retroprocessing center, which have a large equipment to disinfect flexible endoscopes with 6 cabinets, 8 retroprocessors, 3 plasma typhon, either to to dry endoscope and to store endoscope. We have a park of 200 flexible endoscope from 9 different units. I guess gastroenterology, urology, ENT, ICU, pulmonary endoscopy, etc., etc. And we have also 2 robotic transports, because this center is far from different activity from the operating room or for the pediatric activity. I will show you in next slide 2 pictures of our robot transport. 7 air care workers are working in our center from 8 in the morning to 7 to the morning to prepare the endoscope for the program of the operating room to 8 in the evening. This is some data of our activity. We perform more than 20,000 cleaning disinfection cycles per year. We treated every day more than 120 endoscopes, and you can see the activity is increased year after year. So what are the key factors for a retroprocessing center like that? It's the user, and Professor Arcidiacono will talk after my presentation and will explain his activity. Bedside pre-cleaning right after the exam. Transports, you can see here our 2 robots that perform, I think, more than 100 kilometers per month for around 1,000 travels between the center and the different wards with endoscope activity. Then manual cleaning and brushing, automatic cleaning and disinfection in the retroprocessors, and then transport to be dry, first of all, with this material, the plasmatifon, and then to be stored either in cabinets, but we have only 6 cabinets, which each cabinet has only 8 places for store endoscopes. So we need to store endoscope with another way, and we choose 3 years ago to store endoscope with the plasma bag with the same delay of 7 days. So what about the virus? What is new? What is the challenge? So I choose some important new data. And I would like, first of all, to show you this map. Maybe you know and you follow every day the evolution of the number of cases through the world. Of course, this number of more than 4 million people through the world is probably underestimated, because we don't test every patient, because, as you know, around 20% of patients are asymptomatic, but they are infected. And you can see here the list of the different countries through the world. And you can see for the 2 speakers today, Italy here and France here, with around 200,000 cases. And you can see here the number of deaths for each countries, with around 100,000 deaths in Italy and 26 in France. This is a map of my country. I'm living here. Nantes is here. It's a very large town, about 500,000 inhabitants here. And you can see in front there is different situation of the spread of the virus. At Paris, the region of Paris here, and the east of the country are a very high level spread of the virus, and the west coast here is less affected by the circulation. Today in my hospital, we have this morning only 8 patients in ICU and 50 patients in medical wards. COVID positive patients, of course. So, as you know, probably how to guess the diffusion of the virus, and we use this basic reproduction number. It is the probability that a case here we give the virus to other people, and we know for this SARS-CoV-2 that this number, this AR0, is probably was during the peak, within the outbreak, between 3 and 4. And if you want to control the outbreak, you need to decrease this number to less than 1. And this is the situation in Europe, in Germany, since the 22nd of March. This AR0 is under 1. So the spread is decreasing. And of course, if the AR0 is higher than 1, you are in outbreak situation. I would like to say also that what about the patients who have present severe infection with pneumonia or distress, respiratory distress in ICU? But we observe now that those patients that are discharged from hospital had long-term consequences, such as cardiovascular sequelae, myocardial injury, arrhythmia, cardiomyopathy, and heart failure. This is an important point. Are those patients, when they are discharged from the ICU, they can't go home. In fact, they have to go in pneumology or neurologic rehabilitation to be taken care. If you want to compare different infectious diseases and the way of spreading, we can compare in this slide here the measles, for example, rotavirus, here tuberculosis, variole, and here you can see the position of the SARS-CoV-2 virus with a AR0 between 3 and 4. Another data from the ECDC that the virus has been identified in respiratory tract specimens 1 or 2 days before the onset in symptoms. It was really a very important question at the beginning of the outbreak, because we believe first that only symptomatic people can transmit the virus, but in fact, before you present symptoms, you can be contagious and transmit the virus, and you are contagious up to 8 days after the beginning of the first symptom. So the high viral load close to symptom onset suggests that the virus can be easily transmitted at an early stage of infection. But even if viral RNA has been detected in feces, wool blood, serum, saliva, probably, as you can see in this slide, the main way of transmission is via droplets. You know, it's a direct respiratory transmission when you are close to another people, probably within one meter, of course, and if the infected patient have symptoms. Okay. So some data about tests. As you know, we have 2 different way of testing patients. You can use RT-PCR. That's a test used for the diagnosis. If you have symptoms, the PCR can diagnose the infection. And probably, as I told in the preceding slide, the PCR will be positive if you do it at the right time. I mean, not not in a stage pre-symptomatic, because probably you haven't enough viral load in the nasopharyngeal. So you need to perform this test at the beginning of the symptom, and if you do this test too late, after 8 days probably, this test can be negative. And you also heard or read that 30% of symptomatic patients are negative with RT-PCR. It's not false negative. It's because you didn't choose the right time to do the test. Because if you perform RT-PCR at the 5 or 6 day after the first symptom and you have a pneumonia, the virus is in the respiratory tract and is not yet in the pharyngeal area. Then the second test is the serologic test. It's not to diagnose a current or an onset infection. It's after the infection, later, maybe 10 days, 20 days, you can perform this serologic test to know if you have been in contact with the virus, and if you have antibodies and you are quite not contagious for other contact around you. So this draw show you the most infection periods when you need to perform the RT-PCR test, and this period later, then antibodies appears. It's a serologic by blood sample. It's not a nasopharyngeal sample, and appear first IgM and then EDG. Currently, we don't know, 1 month later or after your infection, if the rates of antibodies is quite sufficient to protect you for a long time. We don't know that currently. So what are the French recommendations? I'm currently writing for the health ministry. Is do not systematically screen all patients hospitalized in healthcare setting. Of course, screen by RT-PCR symptomatic patients. And when you take care now after the lockdown in many countries in Europe, and you start again particularly your surgical activity, what about the infectious status of the patient? So we recommend to screen patients who have been in contact with a proven COVID-19 patients within the last 7 days. Also, patients with comorbidities at risk for severe forms of COVID-19 infection, and patients benefiting from invasive procedure or therapy, including, of course, endoscopy, which the occurrence of an infection could have serious consequences. So we define major surgery like cardiothoracic surgery, digestive surgery, also organ transplantation, etc., etc. So what are the recommendations to ensure that the risk of infection is minimized? So first of all, in this draw, you can see we need all together in hospital, but also in our life at home with friends. Next week, for example, if you have a rendezvous with your friend, you need to respect at least the CDC talk about 6 feet. That means 1 meter and 80 centimeters. In France, we define this social distance about at least 1 meter. But of course, if you are doing bicycle, if you are doing footing, you need to increase this distance to approximately 10 meters. If you only work, you need to be 5 meters away from another people. This is the physical distancing. Of course, an hygiene. I don't say that you need to perform an hygiene with hydroalcoholic products, or also by water and soap, because the virus is susceptible to, with water and soap. But when you are in a healthcare setting, it's better to disinfect your hands with hydroalcoholic products before and after contact with a patient, before and after contact with a material, etc., etc. Try to avoid touching your face, because you know that a human usually touch her or his face approximately 60 times per hour, you know. Okay, donc imagine it for 24 hours for days. Have a daily change, and you need to wear surgical mask anywhere, anytime in your hospital. So this is a flow chart from, I think, an Italian publication, and this flow chart is very useful to screen patients and to assess the risk based on a questionnaire, on telemedicine. So if your patient is COVID positive, of course, you need to organize your consultation, your unit, the place where you are performing endoscopy, to have a specific personal recommendation with maximal individual protection, of course, with a specific logistic. I will show you in the next slide how you can imagine the organization of an endoscopic unit, for example. And if your patient is negative, who has not been tested by RT-PCR, you can imagine two groups of patients, a low risk group patients and a high risk group patients. The low risk patient is when a single negative PCR test was done. The patient have no symptoms during the previous 14 days, and these patients had no contact with cases. In this group, you need also to have a protocol and to define the protection for the personnel, and also the organization to welcome and to admit patients in your unit. In this group, the high-risk patients, you have a single negative PCR. Patient presents symptoms during previous 14 days, whatever the symptoms. I will show you all the symptoms in few slides. And also, this patient had contact with a patient who had presented a COVID infection. So you need also to perform a specific organization for this group. And maybe you can combine this group with a high risk with this one, with the positive patients. So this is maybe a draw you can imagine for your area, and you can imagine admitting patients with high risk or positive patient here. But if patient is positive, you need to balance the risk of infection and the necessity to perform your acts. And in function of the group, you can provide some guidelines about the equipment for your healthcare workers. I mean, to wear gloves, to wear a surgical mask if you are in standard activity. But if you are in your oral route endoscopy, you need to wear another type of mask, like this one, that we call FFP2. That probably you know, and probably you used it before, because you are at risk of airborne transmission if you are very close to the patient. You can also wear hairnets, gowns, goggles, or face shield, according to the type of care you are providing to your patients. So what by telemedicine or at the time of the patient is currently take a rendezvous to come in your unit, you can ask by phone, not a doctor, but maybe a secretary of a nurse can ask by phone the patient with those different questions. So, for example, do you currently have or have you had in the previous day any of the following symptoms in an unusual way? This example is I'm currently finish my documents, my guidelines for the national level in France, published by the High Council for Public Health. That I'm working in this national institution half of my time. So in the general population, unexplained asthenia, yes, no. Unexplained myalgia, yes, no. Headache, anosmia, yeah, and you know that anosmia, it's probably occur in 30% of COVID patients, but it's a very, very sensible symptoms to prove the infection. Ageusia also. For an old population, alteration of the general condition, repeat falls, onset or aggravation of cognitive impairment, confusional syndrome, diarrhea, decompensation of previous pathology. For the younger population, all things mentioned in general population, alteration of general condition, diarrhea, isolated fever, but you know that the fever is not always present in childs, etc. And in an emergency condition, recent heart rate disorder, acute myocardial damage, or severe thromboembolic events. So also, if you have no symptoms in this list, you can ask this question: have you been in close contact, face-to-face? This is the French definition for the national public health institution, within 1 meter or for more than 15 minutes. I don't know in Italy what is the definition of a contact people. You need to be in contact without a mask wearing, of course, with a person with a COVID-19 disease. So this kind of questionnaire may help doctors to manage the different risks in the patient population. So that was my last slide, and I'd like to thank you for your attention. And it's now my pleasure to welcome Professor Arcidiacono, which is going to present himself about his activity in Milano.
Thank you. Here we are. Can you hear me? Thank you. Thank you, Professor Lepelletier. Thank you, Monique, for your kind introduction. I can start to go on with my talk, if it's possible. Okay, here we are. Thank you, everybody. As you heard, my name is Paolo Arcidiacono. I'm actually the head of Pancreatic Biliary Endoscopy and Endosonography Division at Raffaele Scientific Institute in Milan, Italy. We actually are a high volume endoscopy division, specifically involved in the diagnosis and treatment of pancreatic and biliary disease. Furthermore, we are located in Milan, and it's, as you know, Milan is in the center of Lombardy, and Lombardy, starting from January 2020, has become the center of COVID-19 pandemic in Europe. And in this slide, you can see what was the situation in Lombardy and in Milan in April 2020, when we had performed the first webinar on COVID pandemic, and these were the numbers in in Lombardy. And on the right, you see the numbers that we had as the inpatient in the world in San Raffaele Hospital. We had at the time 300 inpatients, and among those 45 in ICU. So a huge number of people. And just some 1 or 2 weeks before that webinar, the national Italian government has decided to lock down, establishing for the whole population a quarantine and giving a list of strict hygienic rules to follow. You already heard by Professor Lepelletier. And now we are, after more than 50 days of quarantine, we can see the effect of this decision that the government took in the actual graph of contagion in Italy. As you can see here, this is the curve of the people cured, and this is the curve of contagion that is decreasing. And also you can see here on the map that the colors are going to be lighter and lighter, because the number of contagions is changing, is decreasing. And the same we have also here in San Raffaele institution. So these are the numbers at 13 of April, and these are the numbers of 2 days ago. We have nowadays only 150 inpatient, and among those only 24 are on ICU. So the numbers are really decreasing over time, and considering these numbers, the government has decided to start the post-peak pandemic. Here in Italy we call that the phase 2, and the phase 2 is very important for us, for all the hospitals and for the patient, because this decision will affect the level and the possibility of cure of many patients whose procedures and intervention have been cancelled or postponed due to lockdown, or like in case of our patients who are in most cases oncological patients, those patients avoid to access to the hospital because of the fear of contagion. You know that oncological patients are more prone to be infected as compared to the non-oncological patient. And as you can see here in this left graph, this is the activity of our US division, Endosonography division, where the numbers of people comparing to 2019 are decreased by a mean of 60%. So this is a very important issue. And so which are our goals for this next phase from our endoscopical point of view? First, we want to be able to readmit outpatient with non-urgent or neoplastic indications. And second, to try to speed up the diagnostic and therapeutic processes to impact on the prolongation of the waiting list that has been determined by the pandemic. But until the vaccination is available, there is for us and for everybody a need of a reliable, with a very high sensitivity and negative predictive value, reliable serological certification, both for healthcare workers and for every patient who is going to be admitted to the hospital. That could further help to reduce the likelihood of an undetected case of COVID positive patient in a non-COVID patient area. So we need to try to really to perform some kind of identity card for COVID-19 for these patients. You have already heard by Professor Lepelletier about the different tests, their utility, their pros, their cons. we know that to be highly accurate in defining a person to be COVID-free, probably we would need to perform all those tests, but this is very costly and probably is not affordable for the public health system. On the other hand, we must take on our mind that using a testing strategy to select patients or healthcare workers who are less likely to represent a potential infective source or who are potentially immune to the disease is debatable, but putting this test at the center of the decisional algorithm may lead to a false sense of security and a tendency to release the use of protective equipment and so on, which up to now for us is the safest options that we have, on which we rely on. So what can we do? So what can we do in real life? So I can tell you what we are doing now in San Raffaele, in a geographic area like Milan, where the likelihood to be asymptomatic but COVID positive is very high. From the healthcare worker side, we are actually performing serological tests to all the healthcare workers in the department and in the hospital, and in case of positive, in case of negative test, we will follow and repeat the test after 2 or 3 weeks to continue follow the worker. While in case of positive test, then we will perform a swab, and if the swab is positive, then the physician will go in quarantine, and if the swab is negative, then will be followed and then perform a repetition of the test. But from the patient side, from the patient who are planned to come to the hospital to perform diagnostic or therapeutic endoscopic procedures, this is the big point. There are data from United States and economic analysis of screening strategies that has led to the conclusion that the economic burden of universal screening would be repaid adequately by a reimbursement derived by the increased numbers of procedures that should be performed. However, this would be associated to an increase of healthcare workers' infection due to procedure executed on false negative patients, so with a reduced PPE and expected to be higher with increased infection prevalence. This is very important to keep in mind. So what we actually do in San Raffaele? First of all, we had tried to create a healthcare network. I call it the COVID triangle. That means it unifies the patient, the general practitioner, and gastroenterologist. Usually, after the referring physician has prescribed an endoscopic examination, the gastroenterologist contact directly the general physician and agree with the general physician if this examination is appropriate, is indicated, and also agree on the prioritization of the procedure, taking also into account also patient symptoms and history before. Then, if those two physicians agree on the appropriateness and indication for the endoscopic procedure, then the patient will be called by the endoscopy unit to a pre-screening about health status. You have heard about the questionnaire explained by Professor Lepelletier. We have a very similar questionnaire here, and also the possible consultation on telemedicine is provided to the patient. After that, there is starts the screening process. So after this first round of telephone screening, 48 hours before entering in the unit, the patient has undergoes a swab testing, and any positivity to this step should lead to a procedure deferral, and also to the possibility to define a particular workflow for patient referral to the most appropriate health service. And here we need to perform to do a differentiation, because in the next future, here in Italy, but probably all over Europe and the world, there will be a definition of COVID hospitals, where all the positive patients will be referred to perform COVID positive procedures. But until that time, we need to provide different pathways for different patients. So we need to take care at the same time of COVID positive and COVID negative patients. And to do that, the endoscopy unit should change in the very next future. So here in Milan, every patient, as I told you, will be screened before entering the unit, and high-risk patient or COVID positive patient detected through the pre-admission screening will be deferred and perform their examination in the COVID positive area. So we will provide separated areas and well identifiable path for COVID positive or high-risk patients and COVID negative or low-risk patients, including separated waiting rooms, recovery room, reception, and separated endoscopy rooms. Every patient entering the unit must perform hands hygiene, maintain physical distancing, wear the appropriate personal protective equipment, and the high protection equipment must be worn in the COVID positive high risk area. For the people accompanying our patients, no accompanying person will be admitted to the COVID positive area, and only one accompanying person will be admitted in the COVID negative area. Looking to the COVID positive area and looking to the healthcare workers, there should be no promiscuity in the personal working in this area. So the same team of healthcare workers that works and must occupy only one of the two environments and remain together for the entire schedule, so as this compartmentalizing of the personnel should minimize personal exposure. So this means that the people who are performing COVID positive patients will perform COVID positive patients for all the day, and usually we project to rotate the personnel on a bi-weekly basis in order to reduce the physical and psychological burden of working in a high-risk environment. The assistance in the COVID positive area might be then followed by a week off at active turns or triage or something like that, not in the COVID positive area. And we project also, before starting a 2-week period in the non-COVID area, to perform another swab in order to be sure that the healthcare worker is not being infected during that rotation. Sometimes the endoscopy department, according to the local realities, a space confinement might also be associated to a time confinement. So this means if you don't have the possibility to separate two different areas for COVID positive and COVID negative patients. In this case, you can perform two different sessions. A morning session in which you perform you would perform the COVID negative patients, and after a complete sanitization and disinfection of all the rooms during the afternoon, you could perform with a second healthcare workers team, you could perform the COVID positive patients during the afternoon. So obviously, if we think about the personal protective equipment, to my opinion, nevertheless, the COVID negative area could be treated in a more relaxed, if I can tell you, way. My feeling is that probably, particularly in a very high endemic pandemic area like Lombardi, the healthcare workers should use also in the COVID negative a full personal protective equipment like this in the picture, and moreover it would be very important to standardize a sequence of managing the instrumentation, then also how to exit the room from at the end of the procedure, and particularly it would be always important to follow strict guidelines for dressing and undressing the personal protection. Also will be very important the reprocessing and cleaning of the instrument, because in most of the endoscopy centers there will be no possibility to have two different sets of instruments for treating COVID positive and COVID negative patients. Particular attention should be taken in the washing and disinfection procedure, particularly in case like this of a duodenoscope. So in case of the RCP scopes, to reduce to the minimum the risk of contamination. Nevertheless, we know that the virus is inactivated by the standard cleaning procedures. The use of a disposable tip, like in this case, like a disposable tip, like in this case in the deck, as you can see here, will provide the possibility to perform a very easy and perfect cleaning of all the working channels and the instrument channels in order to be absolutely effective in the cleaning and in washing and disinfection. And at the end of this process, you have already heard about the possibility to perform a better drying and also better storage of the sorry, it's not working. A better storage of our instrument. We actually used for that particular drying modality with the Typhoon, with this Typhoon plasma bag modality, because this helps us to completely dry the working channel of the instrument, and this is very important because hampers the creation of the biofilm that usually are the part that should be infected by bacteria. And as a second, we can use this plasma bag in order to store the instrument completely in a safe way, and to use the ozone that we know is a gas that can destroy 99% of the viruses and bacteria. So with this modality, we have the possibility to store in a safe way this instrumentation, and to be able to reuse very quickly the instrumentation from one COVID positive to one COVID negative patient, but also to store this instrumentation at least till 30 days in advance. So this is my last slide. Is just a resume of what we have told you during this webinar from my side. So thank you very much again for your attention, and we can go back to Monique for the moderation.
Thank you very much, Professor Arcidiacono, and also Professor Lepelletier, for your valued comments and very well respected experience in the field. So now we have some time for some questions, and thank you very much for the audience for asking some very valued questions. So maybe I start with some questions for you both at this stage. So our first question is, in low-risk patients, do your endoscopists change their PPE for each patient or just for a list?
That's a good point. Actually, we are using the same attention for so-called low-risk patients as we use for high-risk patients. So during these days, I don't know, since the next week, when we are going to reopen to the outpatients, so the number are going to increase a lot. But during these days, we act the same for COVID positive and COVID negative and low risk patients. So using the standard PPE, and then throwing away after every single examination.
Okay, thank you very much. And again, it's a question about low-risk patients. So in low-risk patients, do you leave the room vacant for significant time to allow for air exchange?
Didier, do you want to answer?
In French, our guidelines specifies that you need to have a 15 minutes period between two patients and to open the door if possible.
Yeah, actually, here we use negative pressure rooms. So usually we have at least 15 minutes also for negative pressure rooms, because usually when the time that you use to change the patient is nearly 15 minutes. If the patient is COVID positive, then we perform a complete disinfection of all the rooms, so this takes a longer time for sure.
Yes,
okay,
and 15 minutes corresponds to the delay of the cleaning the environments. You need to wait the drying of the disinfection products. Yeah. So 15 minutes, it's a good period, both to change the patient, to clean their environments, and to wait the new ventilation of the area.
Yeah.
Okay, thank you very much. So on the topic of disinfecting, we have another question here. If there's any recommended specific type of disinfecting agent for nasal endoscopes?
For nasal?
Mm-hmm.
We actually use the same kind of disinfection, and they go in the same machine, the same washing machine. So the procedure is absolutely the same for the standard endoscope and the nasal as well.
In our center in Nantes, we have a specific retroprocessor. We have 8 retroprocessors, but one is specific to ENT endoscopy.
Okay.
But there are no channel in those kind of endoscopes, so we don't need to disinfect every 12 hours endoscope. So we just have to perform detergents for that kind of endoscope.
Okay.
But there is no specific procedure currently during the pandemic COVID-19.
Okay, thank you very much. Professor Lepelletier, this question is for you. Could you please give us a quick overview on the guidelines that you're writing for France and an indication of when these will be available?
Oh, there were so many guidelines. So 2 months. I wrote 10 guidelines for the French Society of Infection Control and more than 40 guidelines for the public, the Ministry of Health in France. So there is no specific guidelines for endoscopy because that is the specific Society of Gastroenterology who did that, but not at the national level at the Ministry of Health. But we wrote so different guidelines to the population, how to go to the deconfinement with success in the population. We wrote guidelines about effluents, about ventilation, about how admit and provide care in COVID-19 positive units in healthcare settings. This afternoon, I'm going to start a working group on aircraft, but we did that in school, in building, for society, in the industry, for example, etc., etc. We have several guidelines, but the most important thing to say is to understand that to control with success the spread of the virus, whatever the area, is to respect standard precaution. I need protection of the people, of the healthcare workers. If you are in any healthcare setting, you need to improve your hand hygiene, of course, several times by day. You need to organize how you can start again surgical activity in consultation, because when we were all the European country, we were in lockdown. We stopped usual activity to only admit in hospital COVID-19 positive patients. So now we start just this week to start again surgical activity, because all the surgeons in France were awaiting to start again the surgical activity. And maybe we have a lot of damage or consequences, because most of French people hesitate to go to hospital, wait to go to hospital, and particularly when there are cancers, probably we'll take care of patients a little bit later than we should do without the pandemic. So this is a real problem in France, but I guess in Italy, that during 2 months, the European population stayed at home without the care they need in this moment, you know.
Thank you very much. So I'm just looking at the time, and I think we have time for maybe one more quick question. And this is about the capacity to test all staff. So the question is, do you have the capacity to test all of your staff and low-risk patients when you return to near normal and pre-COVID-19 endoscopy frequencies? So when you're resuming normal activity pre-COVID-19.
I don't know. I don't know when we're going to resume the normal activity. Actually, we are testing all the staff. So all our staff is already been tested during these days, and I think that we are planning. There is a plan to retest test again if they are negative during the time in the next future. Regarding the low-risk patients, up to nowadays we have decided to test everybody. But to test everybody, we have decided also to have no a close number of admission to the endoscopy. So unfortunately, we cannot open the endoscopy as before COVID because to test all the patients that we want to admit, we need to have limited numbers. I hope that in the next future, probably these quick tests are going, and probably I hope that these quick tests could be also cheap tests will be available, and so at that time we could be able to test all the population and all the people who will come to perform endoscopy procedures.
Well, thank you both very much. So unfortunately, we've reached nearing the end of our time for the webinar. So I'd really like to extend our thanks to you both for giving up your valued time, especially in the midst of this COVID-19 pandemic, and sharing your expert experience, advice, and knowledge with the market. So thank you very much.
Welcome.
And thank you. And just to sum up the webinar, we've had a lot of, let's say, compliments and successes from the market to the knowledge that we're sharing. And we've also planned another 3 webinars coming up. Thank you. So our future plan at the moment, we have 3 webinars planned, as I mentioned. The first one is coming up in a few weeks on the 3rd of June. And the topic is multidisciplinary management of COVID-19 affected patients and when to perform bronchoscopy. And this is by a key expert in Italy, Dr. Michele Bezzi. In addition, we have on the 17th of June, a webinar from 2 key experts in Germany, Professor Markus Neurath and Professor Timo Rath, talking about the daily challenges in endoscopy in the COVID-19 pandemic. And on the 8th of July, we have 3 key experts. So we have a 3-pronged approach from Dr. Cesare Hassan from Italy, Ulrike Beilenhoff from Germany, and Paul Cesar, reprocessing expert from the Netherlands. And of course, we will have more webinars in the future. So if you have some suggestions of webinars that will help you in your market, please get in touch with us either through our LinkedIn channel or through our website contact page. And of course, we mustn't forget to thank you all for your dedicated work in healthcare and really keeping the global community safe. And we hope that you've got some value out of today's information, and we thank you again for your participation and wish you a lovely day. Thank you from all of us here. Goodbye.